welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge. I am very happy to be joined today by...
Hi, I'm Ben Lovell. I'm a consultant in acute medicine working in London.
Fantastic. Ben, I am very excited to be recording this episode on a quite a late Sunday night, actually. So let's get down to a case.
Well, I have a case for you. It's a case where I'm interested to know if you would have followed the same path I would have done, and just to get its sense checked with you, really. It's a case of a 56-year-old woman who came in on the acute medical take. She's referred to me by the emergency department as a known type 2 diabetic who was in HHS due to diarrhea and vomiting. So hyperosmolar hypoglycemic syndrome. I went to see this patient. She was in RESA, and I noted that she had a background of type 2 diabetes, which she took metformin and gliclazide, and was also on once-a-week semaglutide for. Her other past medical history was hypertension, and she took ramipril for that. And I went to see her, and she told me that she'd had really bad diarrhea and vomiting for a week. She could not think of a trigger. She lived with her daughter, who did not have any similar symptoms, so it wasn't something that they put on the kitchen table. And she said that she was vomiting up food and now fluid, and importantly, all of her pills. She couldn't keep them down. The vomit was gastric fluid, a bit of bile, but no blood or anything more sinister than that. I've told you about her past medical history and her drug history. And when I examined her, she was dry. Everyone's got their own way of working out fluid status in a patient, and I'm sure the inter-observer variability is quite high, but to me, she was very dry. She had a dry tongue. She had very cold peripheries up to her elbows, halfway up to her knees. And importantly, I asked her, do you feel thirsty? She said she was choking for a drink. She was incredibly thirsty. And that's always a question I ask when I'm trying to work out fluid status, because I find it's just an easy one, and it tends to give you quite a nice little answer. Her abdominal exam was actually normal. There was no tenderness, there was no pain, there was no rigidity. And looking at her observations, she was afebrile. Her blood pressure was good at 133/75. She was tachycardic at 128, which was sinus rhythm, and her SATs and her respiratory rate were fine. And there was nothing else on examination that alarmed me at all. So far, so dry. I did her blood, or in fact, I didn't get her lab blood straight away, but we have a super duper blood gas machine in our ED, which gives you pretty much every result your serum bloods would give you. And I can see on this venous blood gas that was sent by the emergency team, she had a glucose of 30, so that was elevated. She had a sodium of 127, slightly down. Her potassium was normal at 4.1. Her creatinine on the gas was 180, and I can see that it was 90 last time she had a blood test about a year ago. So I assumed that to be a doubling from her baseline, and I called that an AKI. Her lactate was 2.6, so that's slightly elevated, our upper limit being 2.2, but her pH and her bicarb levels were normal. And finally, her finger prick ketones were 0.4. So I did little maths, I did my little equation, working out the serum osmolality. I added together the sodium and the potassium, multiplied it by 2, and added the glucose. And I found that her osmolality wasn't elevated. My cutoff for HHS is 320, maybe 330, and her osmolality, because the sodium was slightly down, came out at normal range. So it wasn't, in fact, HHS, but she certainly was hyperglycemic, but fortunately not ketotic. I wrapped this all up in a nice little impression. Diagnosis, AKI stage 2, due to 1 week of DNV, possibly infected precipitant, I wasn't sure, associated with hyperglycemia, but no ketosis or hyperosmolality. Plan, antiemetics, IV fluids. I decided to give her a variable rate insulin infusion, or a sliding scale in old money, because she was not keeping down any food. And I wanted to get a tighter control of her serum glucose. And I stopped a couple of meds. I stopped the metformin because her renal function was bad. Her lactate was slightly up. And I stopped her ramipril because she had the AKI as well. And I figured she probably didn't need it if she was quite hypovolemic. I actually also stopped her gliclazide. And the reason for that was because I remember learning 100 years ago that in AKI, you don't excrete gliclazide, and you're more prone to hypos. Subsequent to this day, I've looked that up, and that seems to be a medical myth. So God knows what I've been doing for the last 20 years, but apparently you don't need to do that. do you do that, or was that something that I've picked up?
Do you know, it's not something that I've heard about. However, I do love a medical myth, something that gets ingrained into our clinical practice. And I don't really ever know where it's come from, but it's something that everybody does, maybe in a particular hospital or a particular specialty, that then you go to a different hospital, you do it there, and then it becomes normal there as well. I'm
Yeah.
sure there's a lot of those. Maybe we could do an episode on medical myths.
And I find that with rotational training for training
Mm,
doctors, they bring their myths with them,
yes.
or they
Yeah.
bust my myths. So they're the ones saying, Dr. Lovell, just out of curiosity, which is a nice little preface that people say when they're talking to their seniors, which really means, I think you've gone mad. Just for my
Yeah.
own learning.
That's my own learning.
Just my own learning. Why are you stopping that? And then, so
Mm.
sometimes I learn from them. Now, so far, any issues there, or is that straightforward enough? I haven't tried to trick you. That's not that. That's the yeah.
So 56-year-old female, past medical history of type 2 diabetes and hypertension. She's on 4 medications, which she stopped a few of them. You mentioned that her examination, she was very dry, but apart from that, nothing significant of note, apart from some tachycardia. I have to say, the impression that you've given and the management plan sounds exactly what I would have done,
Oh,
to be
good.
honest, in the exact same way that you said it, which is very interesting. I guess there are a couple of things that I was starting to think about. Number one, her creatinine, for somebody who's got DMV,
Mm.
diabetic, and on ramipril, I may have thought that would have been a bit higher, but wasn't too bad. What was her urea, by the way?
Oh, interesting question. We don't get ureas at my hospital unless you ring up the lab and add it on.
What?
Yeah,
Really?
it was.
Oh,
I've got another topic what I'm gonna bring up a bit later, but it was felt that ureas were only really needed if you were confused about causes of renal failure, pre-renal dehydratation, or if you needed it for working out someone's Blatchford score, if you thought they had a GI bleed. So you can have a urea, but they don't automatically appear on your blood tests chez moi at the current period of time.
that is really interesting.
Mm.
So if we can do that for ureas, do you think we can do that for D-dimers?
And welcome everyone to another episode of Ben and Amy complaining about D-dimers.
Ben and Amy's soapbox. Okay, actually, I completely agree with what you said. The sodium is a bit low, but that's probably because she's dry as well.
And also because the hypoglycemia, maybe I thought it could be pseudo
Absolutely.
hyponatremia or
Yeah,
simple hypovolemic hyponatremia, or a bit of both. Why not?
yeah, absolutely. Her lactate was just a little bit high, which I would have expected. Interestingly, her bicarb and pH were normal, which I guess I would expect that in a type 2 diabetic anyway, unless they were potentially on other medications for the type 2 diabetes. And she's type 2 diabetic as well. She's not type 1 on insulin. So at the moment, there is nothing at all that
Mhm.
seems out of the ordinary, but I know that something
Okay,
to change things.
time for chapter two. So about 20 minutes later, I'd moved on to another patient, and then I received a bleep from the lab, biochemistry. And something that happens at my hospital, if biochemistry get a result they think I might be interested in, or they think might entertain me, they will ring it through. And they rang it through and said, just to let you know, have you seen the CRP for your patient? I said, no. They said it's 560.
Wow, 560.
Is that a record for you, or can you beat it?
I honestly have never had a CRP that high.
That was my record as well,
Okay.
560.
So I
So,
guess the first
yeah.
question I would ask is that definitely right?
Do you mean is it the right patient?
Is it the right patient? And is the machine made an error? I would always, when I get a result like that, whether it's
Mm.
a blood test, a CT report, or I look at a scan and I think something doesn't fit, I double, I second guess it, triple guess it, quadruple guess it. And particularly with a high CRP like that or a high potassium, I always think, is that right? Is that the right patient? Is definitely that the right result? Has there been an error somewhere? Because that is pretty sporting CRP.
I often have that reaction to gas results. I
Yeah.
feel anecdotally that ABG machines are slightly more prone to errors than the ones that go to the lab. Maybe it hasn't been washed, or there's been a clot. I don't know what's going on in its innards, but I can think of a few examples in my career, even relatively recently, where I've had a weird gas result. And I've said, run it again, and it's come up okay. And sometimes you know because it's just incompatible with life. like a hemoglobin of 20 or a pH of 6.5 or something that in a relatively well patient, or sometimes it just bucks the trend if the patient's having ethereal gases, and then you get this really weird one that you think this is a bit funny. I've never seen a lab assay error for a CRP before, but I guess it's a good thought because the patient certainly, she wasn't even febrile, let alone profoundly septic. Um, Assuming that the lab was correct, what would your course of action be in this patient? She'd now gone upstairs to the ward, but it's only a flight of stairs away.
So that is so, and it's such an extreme result that I would want to go back to basics again. And I would think about, I need to go back and ask some more questions. I need to do maybe a more focused history taking, focusing on, is this infection? Is there an underlying inflammatory process that isn't infective but is inflammatory? Another examination, so repeat the examination of what I've already done, maybe focusing on lymph nodes. Is there any lymphadenopathy? Is it definitely not a temperature? I would also want to do simple things like let's dip the urine. She's 56, so that would be appropriate, although it's probably going to be a lot of glucose and ketones in there, but it'd be interesting to look at. I would also start to think about, with that CRP, what's causing it? So is it inflammatory or is it infective? And where am I going to be going next? Do I need to do a chest x-ray, blood cultures? Simple things to start off with first, making sure I'm not missing a barn door pneumonia. That's made her also have some diarrhea and vomiting potentially. I've seen that happen before. I've also seen diarrhea and vomiting with urinary tract infections, actually. So really focus on that urinary history taking, the abdominal history taking. I mean, it's a very short history of 1 week. So things that I'm starting to think about, like inflammatory causes, like autoimmune disease, seem a little bit more unusual because it's quite a short course. However, I guess somewhere in the back of my mind, that's what I'm starting to think about.
So exactly, I thought I need to do a very intensive septic screen here. We'd done one at the front door. She had her X-ray, she had a urine dip, as everybody does, and they were really really blameless. So I went back to the ward. I said, "Hello, me again," and I examined that woman from head to toe. I mean, from hair follicle to toenail. We started at the top and worked our way down. I was in her ears, I was in her throat, I was feeling lymph nodes. I did a breast exam. I looked at every square inch of skin I could get to. I was feeling her joint, um, looking for something that was throwing off a CRP of 560. That cannot be quiet, whatever it is, infected, inflammatory, paraneoplastic, you name it. Surely good old fashioned clinical skills should be able to determine what the infection is. And I examined her intensely. The only thing I could find, she had a bit of a tender lumbar spine. She said she'd had it for ages. She had a good range of motion. I pummeled the spine and the paravertebral muscles. And she was like, yeah, that is a bit sore, but I do have chronic sort of lumbar back pain. And I thought, discitis, I've seen discitis before. It does give you triple digit CRP discitis, but they usually are an excruciating pain. Like they can't tolerate motion of the spine at all. And I thought it's a bit of a weak connection. I wasn't really buying it myself. So I came up negative. I could not find where this infection was coming from at all. And, it was the evening, it was about 8 p.m. I was clocking off in an hour. And I had to make a decision about whether we just watch and wait or whether I gave her empirical antibiotics. And before, please don't twist your face at me, young woman. I can see when you give antibiotics without a source empirically, I think it's often a knee-jerk reaction because what we're treating is a hyperCRPnemia, however you want to call it, and a source. And we said very often on this podcast, treat the patient, not the numbers.
Yeah.
But that 560, it was a record for me, and it made me feel deeply uncomfortable. What would you have done, Amy?
I completely agree with what you did. You went back and saw her and examined every part of that patient, which is absolutely the right thing to do. What I always tell people to do, and I think they look at me like I'm going crazy sometimes, is look at people's feet. You can tell a lot about a person from their feet. Look at their toenails. Is there any vasculitic process that could be causing that high CRP? Is there any cyanosis? Is there any clubbing in the toes? Look in between the toenails. Is there any athlete's foot? Is there any breakages in the skin? Is there any evidence of cellulitis? Is there any evidence of any gout? So, I've seen gout occasionally cause high CRPs, although, to be honest, never a CRP of that high. So you're asking me if I would have started antibiotics or not, aren't you?
Yeah,
And
exactly. You're allowed to say no.
I think, okay, what was her white cell count and her neutrophil count?
Her white cell count was 11.4 and her neutrophils were 7.1.
Lymphocytes?
They were normal, 1.01.
So the reason I'm asking that is because sometimes in quite a significant viral illness, they can be quite
Low.
suppressed. We
Yeah.
saw it in COVID as well, didn't we? Quite a lot when you have that lymphopenia. I think with a normal white cell count, a normal neutrophil count, afebrile, nothing to find in examination, normal chest x-ray,
Mm,
normal urine dipstick,
mm.
I would probably have got a second opinion,
From who?
potentially. In the daytime, I would have asked another colleague, a
Mm,
consultant colleague. At 8 o'clock at night, when I'm having difficulty in making these decisions, I verbalize it and talk it through with the doctors who I'm working with, regardless of their level of training. And I found that really helpful to actually talk out loud what's going on in my head. And sometimes by doing that, that helps me make a decision. I think, in fact, I know I wouldn't have started antibiotics. And I've probably got lots of people saying you should have done, you should do, you should do. But I think given the whole picture,
mm.
I wouldn't have. And also, antibiotics have risks themselves.
Of course, yeah.
So if you don't have a clear source of infection, blood tests are okay apart from this very elevated CRP. It's a spurious result. It's incongruent with what else is going on with the patient. However, on that side of things, her heart rate's a little bit high and her lactate's a bit high.
But she was dry. She had an AKI stage 2.
Okay, but is she septic?
That's the question, I guess.
So now I'm starting to think about we've got a tachycardia, we've got a slightly elevated lactate. I've had a patient who's been unwell for 6 to 7 days with a high CRP. Yes, I would start antibiotics because I want to make sure 100% that this is not sepsis that I'm missing.
Is that your final answer?
Yes, because she had cold peripheries, he
Yeah,
said.
yeah.
That could be a sign of sepsis, not necessarily dehydration, although she was dry. The AKI could be secondary due to hypovolemia, essentially due to sepsis. Although her blood pressure's okay now, it may have been a little bit low. Yes, I would start antibiotics.
Okay. I gave her antibiotic, but first I did a blood culture
Okay.
because she wasn't spiking, but maybe there was something that we could grow that would guide us further. So I said to my nursing colleague who was in the room with me, I said, can you give the cefuroxime as our antibiotic for infection of unknown origin at my hospital? IV cefuroxime, please. And we'll do a blood culture first before it goes in and we'll see what happens. And my rationale for that was what was the trigger for a DNV? I'd said query gastroenteritis slash food poisoning, whatever you want to call it. I've never in my life seen infective DNV cause a CRP of 560 because, of course, most stomach bugs are viral. But I thought, I wonder if she has got some bacterial or a diverticulitis or a Campylobacter or Salmonella or an E. coli or something, which is causing her stomach, which is given this week of symptoms. That's how I talked myself into it. And so we did the culture and I gave IV cefuroxime. So we did the same thing. I know there are many other people who would, for very excellent reasons, would be justified in saying you cannot just go around throwing antibiotics at CRPs like this,
Mm.
antibiotic stewardship, etc., etc., etc. She's in a safe place. If something changes, we can react to that very quickly. So, leave well enough alone. And I get those arguments. And maybe on another day I would have done that, but on that day, that frame of mind I was in, that mood I was in, I went down a different logical road and I gave the antibiotics. So, what happened next? I went home, obviously, and I came back in the next day, and she'd had an eventful night. About 20 minutes after I left the building, she spiked.
Ooh, okay.
Yeah, went up to 39 degrees and had a little Ribor, and had some paracetamol. By the time I did my morning ward round, nearly 12 hours later, her blood culture had already grown gram-negative rods.
Wow.
So micro rang and said, keep giving the cefuroxime and await sensitivities. By the end of the day, they had identified E. coli in her
Like,
bloodstream. So they come back to me and say, yes, your patient's got an E. coli bacteremia. Continue CAF and identify source. But I would love to oblige, but I was unable with my, my hands, laying them on the patient to identify the source. So I don't know what your usual practice is when you have a patient with an E. coli bacteremia, but I always think about the two bladders, urinary and biliary, and think where it's coming from. I went back, I'd look at the LFTs, plumb normal. Stuck my hand to the right upper quadrant, no pain or tenderness up there at all. Similarly, her urine didn't have any nitrites in it,
mm,
didn't have any white blood cells in it, and she had no suprapubic tenderness. I was thinking, could she have colonic, in fact, like diverticulitis or colitis, bacterial colitis, and that's why she's having the diarrhea at least? Any road up, I got a CT abdopelvic. So cross-sectional imaging, looking where the E. coli is coming from. Shall I read the CT report?
yes, please. It's just to reflect on something that you said
Right.
about when you're given then the task of trying to identify the source
Mm.
of this E. coli. Again, you went back to the patient and you examined and tried to find, and I agree with you. I always think of bladder. Probably my own bias is that in a woman, I always think of the urinary bladder first. The majority of E. coli bacteremias I do see do seem to come from the urinary bladder. However, I obviously have seen it come from elsewhere. But it's good to have a structure, isn't it, when you're given something like an E. coli, and how do you then address it? Because I have seen E. coli in the bowel as well, like you say. And it's always good to get poo. And I think one of the things we often forget to get from a patient when they have an infection is poo,
Mm.
because it's sometimes very difficult to get that feces sample, particularly if it's very runny, it's very frequent. How do you get it in the bowl? How do you then get it into that tiny little pot that it's expected to be transferred into? And that can be a challenge. But I think that's a key thing to remember, is to get some feces, and also to do another blood culture
Mm.
potentially, and maybe another one as well.
So we did the CT.
Yep.
There is acute pyelonephritis, mainly involving the right kidney, which is markedly swollen and has reduced parenchymal enhancement. No abscess, no hydronephrosis. There is marked perinephric and periureteric fat stranding.
Mm.
I went back to the patient and said, how do you feel today? And she said, I feel a bit better actually since I had those fluids. The vomiting has settled a bit, and I had a bit of breakfast this morning. And I said, I'm sorry I keep repeating myself, but do you swear you have no loin pain? No flank pain? Do you swear you have no dysuria or no urinary frequency? And she's like, no, well, why do you keep asking me that? I said, because you have a very, very severe infection of your right kidney. And it was just very, very shocking to me that the patient was completely asymptomatic of pyelonephritis. I've seen 1,000 pyelonephritis presentations. The classic patient clutching their flank and in terrible pain, rigoring, yes, vomiting. And you did say that right at the top of this podcast, you've seen this sort of symptoms for urinary infections before. So very well done. But I'd never seen it in someone who had absolutely no urinary symptoms at all.
Mm.
She actually became quite sick thereafter from someone who looked a lot better. Her creatinine went up to 500 at one point. She was admitted to intensive care, but fortunately did not need any renal replacement therapy, but she became quite oliguric at one point and was eventually discharged. And I spoke to a renal doctor about it actually, because they came to review her, and they said presumably she had maybe a bit of underlying kidney infection due to her hypertension and diabetes. And then she had a severe AKI due to sepsis and transient hypovolemia. And that all sort of made sense. One interesting thing was when I was talking this over to my husband, who is also an acute medical consultant working at a completely different trust, when I got to the bit about the CRP, he said, oh, why didn't you just do a serum procalcitonin? Do you do them?
Nope.
Why did you really?
Really, it's not something we have ever done anywhere I've ever worked. And I've heard of other people, particularly when I've worked in Europe, who've said, if you did a procalcitonin, I'm like, we don't do those in the UK. And we certainly don't do them where I've worked. In fact, we've never done that anywhere I've worked. The only guideline I've ever read that mentions procalcitonin is the British Society of Rheumatology guideline on the acute hot joint, which
Wow.
mentions the potential of doing a procalcitonin level to help in the diagnosis of septic arthritis. That's it.
So are they ahead of the game? Is this the future?
How sensitive is
Oh, I'm glad you asked me that. I
procalcitonin?
looked it up before the podcast. 90% sensitive and a 91% specificity for bacterial infection. So it compares very favorably with CRP. I wonder how much it costs. I
Do you know,
couldn't.
I was just about to say, how much is it? And
Yeah.
like, is it something that different labs would have different charges? And then should we be thinking about the money anyway? And
Mm.
would you have changed your management plan anyway?
Well, no, because I gave the antibiotics. I mean, I suppose if I had someone with a CRP of 560 and I didn't know what was going on, then procalcitonin being elevated, that would make me feel better about giving the antibiotics. But I would have given them anyway, but maybe just slept a bit better that night after having given
Hmm.
them. But I've never used it anywhere I've worked. I did a bit of reading about it now, and what seems more interesting to me is how you can use it to track when to stop antibiotics, which I find really interesting because at the moment we give antibiotic courses in length of times of how many times the Earth rotates, which makes absolutely no sense at all.
It's very arbitrary,
It
isn't it?
is.
Yeah.
And who's made it up? So UTI, oh, you need 3 Earth rotations. A complex UTI, you need 5. Severe cellulitis, you need 7 rotations of the Earth. That's what you need. And it's completely arbitrary, and it's very weird that's how we use it as the basis for antibiotic therapy. And no wonder we're in such a mess with antibiotic stewardship and emerging resistance. And imagine if you could do serial procalcitonins, and when that falls to a certain level, you could stop your antibiotic. And I'm now looking at all
Wow.
these amazing studies where they say that you can reduce antibiotic time by days, by hundreds of days locally, by thousands of patient days internationally, and save millions of doses of antibiotics if we gave it until the procalcitonin was down, rather than on an arbitrary unit of time, which we call a day. And I find that a bit more interesting actually than at the front door deciding whether or not they've got a bacterial infection. What
Hmm.
do you think?
That is really interesting. I'm trying to, I'm just sort of working through it on my head, what we've just talked about. So I guess I had a conversation with an infectious disease doctor and a microbiologist about length of antibiotic usage. And you're right, guidelines are very much UTI 3 days, cellulitis 7 to 10 days, and particularly like pyelonephritis, it's 14 days. But like you say, it's very arbitrary. And I remember having a conversation where they said you can stop antibiotics when the patient's better.
Mm,
So we always say, make sure you finish that course. You've got 5 days there. Make sure you take all the 5 days. But I remember once somebody saying to me in the hospital, if they are better on day 3, their temperature's down, their CRP's down, they are back to normal, stop antibiotics.
mm. And let
Now,
the immune
again,
system do the rest. Yeah.
absolutely. Again, this is going to be very individual on how people work, on how different hospitals work, how different departments work, and also on people's training. And it's probably going to be different in healthcare systems where it's you pay for your own healthcare versus where you don't pay for healthcare, and where maybe antibiotic resistance is a problem, although obviously we are finding antibiotic resistance an issue everywhere now. So maybe there is, moving forward, a role for something like procalcitonin to reduce the days of antibiotics? Or have they done a head-to-head trial looking at procalcitonin versus clinician acumen? So
Mhm.
that's it probably hasn't happened, and I can't imagine it ever will, but do we need procalcitonin, or do we need better education as doctors to think about actually for patients, well, they're apyrexial, they're going home, do they
Mm.
need antibiotics anyway?
And how many patients do truly have a rebound infection? I really can't think
Mm.
of any patients I've treated where that's happened, where they stopped
Mm.
them too soon, and then their symptoms of sepsis that it came back. So I think you're right. I think we give way too many. I think we give
Mm.
antibiotic timings are based on arbitrary
Mm.
judgments, which don't really add to anything. I don't know. Oh, you've got a deep-seated bone infection. You need a whole circle around like a moon circle. You need a month of antibiotics for this one, and it just makes me wonder
Yeah.
whether or not we are really just throwing it away. Of course, daily procalcitonins that's it might be expensive, and maybe
Mm.
it'll offset the cost
Mm.
of using too many antibiotics. Clinical acumen is free, sort of, but it means you have to be patient and see them regularly
Yeah, that's
to
true.
make the judgment call when to stop it. But then, of course, if you're having daily procalcitonins, the patient must be in the orbit of a healthcare provider of some description. It's interesting.
It's really interesting because it also makes me think about, again, we give antibiotics to huge numbers of people, but often what we don't think about is the downside of antibiotics and the side effects of them. And the fact that it can affect the liver and the kidneys, it can make people have really awful side effects.
Mm.
And sometimes people do have anaphylaxis to it. So although we prescribe them frequently, they're not without their
Mm.
risks either. And I'm sure we all give antibiotics when people don't have bacterial infections.
Mm. And I
Not
think,
intentionally, but because that's what we feel. We're not sure what's going on.
and that's me and you with our CRP results. So I can only imagine what our
Yeah.
colleagues are doing without
Oh,
that CRP. They are really, flying by their clinical acumen in their prescription as well. And that takes a lot of skill, I think,
absolutely.
make those judgment
Absolutely.
calls. And you've got to be prepared to have a lot of conversations when what you think needs antibiotics and doesn't quite chime with what the patient thinks, i.e.,
Mm,
I want them for my sore throat, and you have to say you don't need them for this
mm.
sore throat. And those are conversations which would really I find quite challenging on the daily basis. Yet that's what they are doing. So props
And I
to them.
think when people come to hospital, whether they've been seen before by somebody, another health professional within the community, they come to hospital and sometimes people expect antibiotics. Like you say, it's really difficult to then have that conversation that says that they actually don't need them. That can be incredibly difficult sometimes. And what I'm finding more and more now is when we are getting busier and busier and busier, the sheer number of people we are seeing does mean that our time is limited sometimes.
Mm-hmm.
And it does make more challenging conversations around whether we should have antibiotics or not. It makes it hard.
Yeah.
And I'm not saying that that's the right thing, that we shouldn't be having these conversations, that we should just be given antibiotics anyway, because I don't think that either. But sometimes the whole working day and that cognitive load that is on us, sometimes it's very difficult to have that conversation.
I think this is a very honest and I think universal feeling because if you have 20 patients waiting to be seen and you're already running very late, and you can either have a 15-minute two-way back and forth with the patient in front of you and with a mini lecture about antibiotics and why they don't need them, or you could write them the prescription and have this consultation wrapped up, and maybe you can actually see the rest of the patient. Maybe, oh my gosh, you could actually have a lunch today or finish less than 2 hours late. And you can see why that path of least resistance might be taken every now and again, even if it causes a moral injury to the practitioner. And even though they know that they probably don't need the antibiotics, but I've got to get on, I've got to keep everyone else safe. What's the overall distributive justice here in treating all of my patients rather than this one in front of me? I can absolutely see that happening. And I think it's a human response.
Yeah, absolutely. I find that the more we're getting into the winter now, it's, well, to be fair, I don't think we ever really had a summer. We always say we're getting into winter now, we've got winter pressures, but actually the summer was just as busy as the winter. I find that I am maybe feeling a bit more uncomfortable at work in the way that I'm not doing things that I feel are unsafe at all, but I may be spending 5 minutes less with a patient than I would have done a few years ago. And
Mm.
you're right, sometimes that cumulative moral injury is really distressing
Mm-hmm.
because I don't feel like I'm the doctor that I want to be, or maybe the doctor that I was 5 years ago,
Mm.
because we're working in a very different system now, a very different environment, which can be incredibly, incredibly challenging and sad, actually.
And that can be where it can drive the clinical decisions you make, but it could be something as simple as this patient is really interesting and I want to talk to them about their life.
Mm.
I want to
Yeah.
ask them, what did you said this happened when you were at the theatre yesterday? What were you seeing? Was it a good show?
Yeah.
I want to see that.
Yeah.
Did you enjoy those in this other show that's opening next week? Little conversations I want to have with other human beings who are my patients, but
Mm.
I've got to be quite military about it because I've only got a certain amount of time to spend at each bedside, and there is a loss there that I do feel.
I think what you're saying is we've sort of lost the human side of being doctors. So when they tell me they have a pet, what have
Mm,
you got? Is it a dog? Oh, I've got a dog. What's your dog called?
mm,
And it's those conversations that actually often lends themselves to them telling you more in the history. You get a better picture. You're
mm,
able to build up a better clinical picture. You're able to formulate better diagnoses and better management plan, but it's going to take 20 to 30 minutes more. And I've got 16 or 17 people waiting to see me. And it's difficult. it sometimes feels like a bit of a burden, like a weight on your shoulders, and how you're going to manage that.
And I worry sometimes about setting bad examples for
Yeah,
trainees when they see me rushing around,
yeah,
spend a bare minimum time of each patient. And I think, gosh, I wasn't taught this. And I feel like the nature of medical education is evolving slightly in terms of bedside teaching because they're seeing me literally say, I've got to move on. I've got to move. Lovely to talk to you. Goodbye. I've got to move on now. And I didn't used to say that as much. I used to sit down, for goodness sake, sometimes at patients' bedside and have a chat and have a look at what they're reading on their bedside table and have a conversation about that. And now, yeah, not so much.
yeah. And I guess the busier we're getting, the fewer doctors and other health professionals. Lots of people are leaving the NHS. I think our job is becoming more stressful.
Mm.
Definitely. Um,
I think
I
our
still,
job is to find the little bits of joy and then make sure people see them as well. Point it out. Point
yeah,
out the interesting bits. And when you are having a good time, make it known. Oh,
yeah,
this is a great ward round. That was a great
absolutely.
job. That's
Yeah,
clerking really good, you know. You know, we got to point that out. That's our
yeah,
as leaders, I think.
yeah. And just two little, I guess, little stories. I was on call last weekend. It was a Sunday, and I was reading a clerking. We're still on paper at the moment,
Yeah.
so I was reading it, and it was this amazing history. And I thought I saw who'd written it, and I was like, right. So I emailed them straight away
Well
because I thought
done.
if I'm going to email them, I need to do it now.
Yeah, yeah,
It'll
yeah.
take 30 seconds. I dropped them an email, and I got a response this week saying, "Thank you so much. That made my day." And it probably took a couple of
It
minutes of
is
my
so
time.
easy to do for us, isn't it?
It's so easy, and I think
Oh,
we need to do it more. And I was with an IMT3 trainee, and she was like, "Oh, that's a really good thing to do." And I was like, "You can do that as well for your
yeah,
IMT1s and
yeah,
IMT2s, and the foundation doctors who you're on with overnight, for example.
yeah,
Drop them a quick email, say this is what you did well. You can pop it in their e-portfolio, and it,
yeah.
just keep waiting for somebody to send me an email saying you did a great history, but I still
Yeah,
haven't
it
got
goes both ways. Where's my good feedback?
my
But I
good.
think it's good. I think, and if we do it and role model it, then maybe it will happen. I think that's good
Yeah.
leadership. And I think it does form a very important part of medical education, which people might call touchy-feely, but I think it's not just teaching people to be good clinicians, it's
Mm,
teaching people to be good leaders because they are going to be leaders
yeah.
in the NHS. And so much of the NHS is built around identifying what went wrong and
Mm,
then examining it. You go to any governance meeting, you look at datixes, you look at any feedback about a service. People tend to only feedback what they don't like and what hasn't going well, and there's a lot of negativity, and there's not very much appreciative inquiry. So maybe that comes from the top, from us.
mm. Yeah, absolutely. I think being a role model is one of the most important jobs we have as a consultant, is to do things well and to tell people they're doing things well, actually. What we're really good at is, like you say, is examining when things have gone badly, but maybe we need to be a little bit more proactive and try to prevent them from going badly.
Mm. Can
So,
you imagine a staff survey going out saying, we want to get examples of good stuff. Please, can you write down what
mm,
we're doing really well and what you like? Just one
mm,
a year. It would just feel so good rather than looking at the staff survey.
yeah,
What do we need to do better at? Oh,
better.
yeah.
I know. I know. You're absolutely right. We need to be more positives. We need to spark joy a little bit more.
Yeah.
So that's going to be my job at work tomorrow, is to
Okay.
spark some joy somewhere.
Pay it forward. One
Yeah.
final little thing, just as the cherry on top of this story, was it's a lot about the case we discussed about the CRP. And I remember working in a department in London, which I shall not name, and their ED, as our ED does not do ureas, their ED did not routinely do CRP. Saying
Mm,
if the medics would like a CRP, they're very welcome to add it on when they, take the patient's referral. But we don't think CRP should be in the remit of an emergency physician. We shouldn't be making clinical decisions based on the CRP. It's not useful. It can cause the muddying of waters and harm. And I remember at the time being absolutely flabbergasted because it
mm,
was, and sort of still is, one of the results my eye does magnetically get drawn to. And I'm going down the list. I find it
mm,
very useful
mm.
as a medic. I remember thinking at the time, I'll happily keep a CRP and trade in, basophils and a red cell distribution width or something instead that I never look at. But I wonder if it's something that's medic specific. Are we more CRP fans than other people?
Maybe. What's interesting though is, in if going back to the case of this 56-year-old female, if we hadn't have had a CRP
I
and
wouldn't
you
have
had
given antibiotics, no way.
However, you did say that 20 minutes later, she spiked a temperature of 39.8. So she would have had them anyway.
Yeah, maybe
Maybe.
not just on the fever, but then maybe that would have
Potentially.
prompted me to add on the CRP. So yeah, a delay was
Maybe. Yeah. Interesting. Thank you so much, Ben. That was an amazing conversation again, as they all are. And I've got some really interesting learning points from that. And as always, nothing is ever as it seems. And every week I say, listen to your patient. They are telling you the diagnosis. However, she didn't. She wasn't telling us the diagnosis because she had no pyelonephritis symptoms apart from
No,
that medical myth that I've got of vomiting is associated with urinary infections, which
it worked out. It was true. Yeah, no, she had no symptoms. Even when I insisted, I went back to her and said, "My good woman, you should have severe flank pain and be rigoring right now." And she's shrugging, saying, "I don't know what to tell you, doctor. I feel a bit better."
oh gosh, thank you. Any lasting final words of wisdom?
I wouldn't say wisdom. I would just say that if you are trying to make a decision about whether to treat with antimicrobials or not, then a really vigorous examination of the patient. I know in this case it did not yield the source, but you'd be surprised how many times we do a chest X-ray and a urine dip, and then we go, septic screen was negative, no source found. Have a proper look. You'll find a hot joint. You'll find that pustule on their back. You'll find whatever it is that's exuding all this CRP or this fever, whatever it is that's made you concerned in the first place. But you've got to look.
Yeah, absolutely. Thank you so much. And thank you to all our lovely listeners out there. It's much appreciated. We are getting some excellent feedback at the moment. So if everybody could rate and review and carry on listening to our podcast, that would be much appreciated. Thanks for listening. Goodbye.
Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.